Welcome. This presentation will be talking about muscle relaxants that can be divided into two categories, those for muscle spasm and those for spasticity. Here is a case study on Tim with low back musculoskeletal pain. Let's discuss some of the drugs that might benefit Tim in the next few slides and then decide what the options are for his treatment. We will cover several drugs for muscle spasm, but I did not include paraffin forte, which is clozoxone, and methylcarbamol. Most all of the drugs for muscle spasm are similar. Diazepam is Valium. It facilitates the action of GABA, which is a CNS inhibitory transmitter. It can be used as an adjunct for skeletal muscle spasm due to joint or muscle inflammation or trauma. It can also be used for spasticity from upper motor neuron disorders such as cerebral palsy. Central nervous system side effects are common. There is a risk of tolerance, dependence, and withdrawal. It's a Schedule IV medication. The Beers criteria recommends avoiding benzodiazepines in the elderly. It's generally avoided as a muscle relaxant due to the risk of tolerance and dependence. Tizanidine is a central alpha-2 antagonist. Its indications include for the management of spasticity. It may also have some efficacy for acute musculoskeletal conditions such as neck pain or back pain. It may be useful for acute back pain for antispasmodic effects, plus its sedative action to give needed rest and sleep. It is very sedating and can cause hypotension, hepatotoxicity, hallucinations, and delusions. It must be tapered off slowly to avoid withdrawal, rebound hypertension, tachycardia, hypertonia, etc. Foods affect absorption and can affect tablets and capsules differently. Tizanidine can be hepatotoxic. Liver function should be monitored at baseline, 1 month after maximum dose reached, and then periodically as clinically indicated. It is contraindicated with potent CYP1A2 inhibitors such as ciprofloxacin, used with caution with other inhibitors of the CYP1A2 such as acyclovir, famotidine, oral contraceptives. There are case reports of QT prolongation and torsades de pointe. For some reason, it's not on the Beers criteria. Metaxalone has an unknown mechanism of action, but may be due to general central nervous system depression. It is used as an adjunct for treatment of acute painful musculoskeletal conditions. It has a relatively low risk of drowsiness or cognitive effects as compared to other muscle relaxants. I use this one often because of this. Serotonin syndrome has been reported when metaxalone is used at higher than recommended doses or in combination with SSRIs, SNRIs, and tricyclic antidepressants. We'll be talking about serotonin syndrome in another module. Metaxalone is contraindicated in patients with significant liver or renal impairment. Periodic liver function testing is recommended in patients with existing liver impairment. The Beers criteria recommends avoiding metaxalone in the elderly. Cyclobenzaprine acts primarily in the brainstem. It is indicated for use in acute musculoskeletal conditions. Cyclobenzaprine may relieve muscle spasms and associated pain, tenderness, and movement restrictions. It is not effective for central nervous system muscle spasm. Serotonin syndrome has been reported when used with SSRIs, SNRIs, tricyclic antidepressants. It is contraindicated with patients on MAOIs. Compared to carisoprodol, dry mouth is more frequent, but dizziness is less frequent. It has the most evidence for efficacy, usually considered first for acute musculoskeletal problems. It should be avoided in moderate or severe hepatic impairment. The Beers list recommends avoiding cyclobenzaprine in the elderly. One other note is that cyclobenzaprine 10 milligrams does not appear to be more effective than 5 milligrams for acute muscle spasms, but does have a higher incidence of sedation. But again, what dose is usually prescribed? 10 milligrams. Just a funny note, I took one of my husband's when I hurt my back one time. I slept for 24 hours straight. It's definitely sedating. Carisoprodol is centrally acting. It interrupts transmission from reticular formation to the spinal cord. It's indicated for discomfort due to acute painful musculoskeletal conditions. It causes euphoria and sedation. There's a significant risk of withdrawal, tolerance, and dependence, making it a Schedule IV drug. Its use is generally avoided due to the abuse potential. One metabolite is meprobamate, which has anxiolytic and sedative properties. It is to be used with caution with renal or hepatic impairment. It's not evaluated in these patients. However, it is hepatically metabolized and renally excreted. The Beers criteria recommend avoiding it in the elderly. Baclofen diazepam. Baclofen is indicated for spasticity associated with multiple sclerosis or spinal cord injury and other spinal cord diseases. It decreases flexor and extensor spasms of the arms and legs. It inhibits monosynaptic and polysynaptic reflexes at the spinal cord. The precise mechanism isn't known. Withdrawal symptoms such as hallucination and seizures is possible with abrupt withdrawal, so it should be withdrawn gradually over 1 to 2 weeks. It should be dosed cautiously in renal impairment and seizure disorders. It is usually the first choice for spasticity. Dantrolene directly reduces the contractile response of skeletal muscle by suppressing the release of calcium in the muscle cells. It's used for chronic spasticity secondary to multiple sclerosis, cerebral palsy, stroke, and spinal cord injury. Interestingly, the intravenous formulation is indicated for the prevention and treatment of malignant hyperthermia, which is a potentially fatal condition caused by succinylcholine and general anesthetics. Dantrolene has the potential for hepatotoxicity that is most common between 3 and 12 months of therapy. It's more common in women, those over 35 years of age, those on concurrent medications, and those taking higher dantrolene doses of 800 milligrams per day. The hepatotoxicity can be severe and sometimes fatal. Thus, dantrolene is contraindicated in patients with active liver disease. Baseline and periodic liver function tests are recommended. Diarrhea may be severe and require temporary or permanent discontinuation of the drug. And if no benefit is seen in 45 days, the drug should be discontinued due to the increased risk of hepatotoxicity. Key clinical considerations for muscle relaxants and antispasmodics. There is very limited good quality evidence to support the efficacy of muscle relaxants. Despite this, these medications are commonly used. Muscle relaxants are not generally recommended for most patients with chronic low back pain due to lack of evidence. Some, such as baclofen and tizanidine, are used for spasticity in patients with multiple sclerosis, spinal cord injuries, etc. Others, such as cyclobenzaprine and metaxalone, are used more for short-term or acute musculoskeletal conditions such as low back pain. Adverse effects are common with all muscle relaxants. The CNS depression commonly seen with muscle relaxants is additive with other CNS depressants such as opioids, alcohol, benzodiazepines, and has led to respiratory depression and death. Muscle relaxants may be used for acute pain that is not relieved with NSAIDs and acetaminophen. They should not be used longer than 2 to 3 weeks, and many recommend limiting their duration to no more than 7 days. Now, muscle relaxants used for spasticity are sometimes used long term. They should be used cautiously in the elderly, as most are listed on the Beers criteria. Agents reserved primarily for spasticity are not included on the Beers criteria. However, consider using them with caution in the elderly due to the adverse effects of sedation and muscle weakness. And there's also reduced clearance in patients with decreased renal function. What else would you want to know about Tim? You might want to know how much and how often he's taken the ibuprofen. Is he taking it frequently enough or in high enough doses for it to be efficacious? You would need to know the degree that his back pain is interfering with his ADLs. Is he going to work? What does he do for a living? If he's a truck driver or operates machinery, you might not want to prescribe a muscle relaxant. For which of the following interventions is there overall evidence of benefit? Only the first 2 on the list have good evidence of benefit. It often is the sedative effect of muscle relaxants that helps relieve back pain. Would I prescribe a muscle relaxant to Tim? Yes, I probably would give him metoxalone or cyclobenzaprine. Cyclobenzaprine has the most evidence for efficacy, but metoxalone has less sedative effects. Thank you for your time and attention. I hope you have a great day.